So, Dr. G Swarroopa, she will be talking to us about plus lenses versus flipper glasses in management of accommodation insufficiency in children.
So, good morning everyone. Today I am going to talk about plus lenses and flipper glasses in management of accommodative insufficiency in children. Now, what is accommodative insufficiency? It is a non-strabismic binocular vision abnormality which is characterized by inability to focus for near vision, and they present as blurred vision for the near, headache, asthenopias and floating lines while doing the near work, which results in the loss of concentration and avoidance of near work, which enters the learning processes of children and young adults. Now, why it is important is because today's technological advances increases the demand of comfortable prolonged near works for all age groups, which led to the further research in the areas of these vision abnormalities, and among those, accommodative insufficiency is the most common vision abnormality, accounting for 17% of the cases. Now, this is a brief introduction about the test to perform to identify accommodative abnormalities. This is a near point of accommodation which is measured by the RAF ruler, and accommodative amplitude is the strength of the accommodation which is given by the 100 divided by NPA in centimeters, and this Hofstadter's formula determines a normal value according to the age of the patient. Now, accommodative facility determines the flexibility of the accommodation, that is, to ability to stimulate and relax the accommodation, and this is tested by the flipper glasses, which has two pairs of glasses, one pair of plus glasses and one pair of minus glasses. Here a target of near vision target is placed at 40 centimeters, and the plus flippers are placed first. When the patient says it is clear, that is flipped to the minus lenses, and this is considered as one cycle, and it is measured by number of cycles per minute. When there is difficulty in clearing the minus lenses, it shows that is accommodative insufficiency, and whereas the difficulty in plus lenses, that shows accommodative excess. Now, monocular estimate method retinoscopy, it is an accommodative response while looking at a near target. This is performed by placing a target, near vision target at 40 centimeters and performing the retinoscopy. The normal values will come up to 0.25 to plus 0.75. When it is more than 0.75, that denotes a lack of accommodation, and when it is less than 0.25, that denotes a lead of accommodation. And negative relative accommodation, it tests the relaxing ability of the accommodation. This is tested by placing plus lenses at the dioptric power of 0.25 increments till the patient says it is blurred. The normal value is plus 2.5 diopters with a standard deviation of 1 diopter, and posterior relative accommodation denotes the stimulating ability of the accommodation, which is tested by minus lenses. The normal value is minus 2 plus or minus 1 diopter. Now, coming to accommodative insufficiency, how can you diagnose a case of accommodative insufficiency? When there is low accommodative amplitude, that is 2 diopters below the Hofstadter's normal value, and the accommodative facility is reduced, and when there is difficulty in clearing the minus lenses, and when there is accommodative lag on MEM retinoscopy with value of more than 0.75, and low positive relative accommodation. Now, coming to the management, foremost important thing is we have to correct the refractive error after the cycloplegic refraction, followed by vision therapy. Now, what is vision therapy? We know that blur is a stimulus for the accommodative reflex, and the disparity and proximity of the near object is a stimulus for convergence. So, this vision therapy involves a purposeful controlled manipulations of the target blur, disparity and proximity with the aim of normalizing the accommodation and vergence system. Now, we will discuss about plus lens reading addition and flipper glasses. Coming to PLRA, how does it work? It decreases the amount of blood to some extent, and this remaining blur is identified within the subject's accommodative capacity. So, when the subject identifies this remaining blur and he tries to clear the image, the blood-driven sensors will stimulate the accommodative system, and that will be normalized. Here, most important thing is we should not correct the full amount of accommodative insufficiency with the plus lenses. We have to keep half of it as a reserve to stimulate the accommodative system. So, how do you calculate the power of plus lenses is by dividing the difference of NRA and PRA by 2. This half amount is kept as a reserve to stimulate the accommodation. Now, flipper glasses, these are two pairs of glasses, one pair of plus lenses and one pair of minus lenses. When we see through the positive side of the flipper, there is a reduction in the blur, and when we see through the negative side of the flipper, there is an additional blur induced. So, when we flip between these two lenses, positive and the negative lenses, there is a controlled amount of induced blur and there is a reduction in the blur. So, this subject has to identify the change in the defocus and try to clear the image. By clearing the image, the accommodative system is stimulated. Now, which is better, PLRA is better or flippers are better? To determine this, we have conducted one study which shows the efficacy of PLRA and the flipper glasses in the improvement of accommodative amplitude in cases of accommodative insufficiency. This is conducted on 50 children aged 8 to 15 years over a period of 1 year. Now, all the children of the age group 8 to 15 years with the best corrected visual acuity 20/20 and the NPA which is worse than 10 centimeters and accommodative amplitude 2 diopters less than the normal Hofstadter's formula are considered into the study. Now, all the patients which have amblyopia, strabismus, nystagmus and prior refractive surgeries or accommodative insufficiency which is secondary to other traumatic brain injuries were excluded from the study. All the cases we recorded the NPA, NPC and accommodative amplitude by RAF ruler and the facility is determined by the flipper glasses. Now, among those 50, 25 children were allotted into the PLRA group and 25 were allotted into the flipper group. And in the PLRA group, we have given +1 reading edition and we encourage the patients to read with these glasses for all the near work they have done. And we have allotted 1 diopter flippers into the flipper group and they are instructed to do 2 sessions 15 minutes each. Now, coming to the results, in the PLRA group, NPA has improved from 15 to 9 diopters with a difference of 6 diopters which is statistically significant, and in the flipper group it has improved from 16 to 8.2 with a difference of 8 diopters which is significant, and in the accommodative amplitude in the PLRA group improved from 6 to 10 diopters, and in the flipper group it improved from 6 to 11 diopters which is statistically significant. This is a bar diagram showing the improvement, and this is a line diagram showing the improvement in the flipper group and the PLRA group. So at the end of 12 weeks almost the values are equal in both these groups, but there is a faster attainment of the normal value in the flipper group. And this is the accommodative amplitude comparison between the flippers and the PLRA. Almost at the end of 12 weeks the results are same, but there is a faster improvement in the flipper group. Now, concluding this, accommodative amplitude is improved both in the flipper group and the PLRA group, but there is a higher level of improvement and the faster improvement is seen in the flipper group, although it is very difficult to motivate the patients to do all these orthoptic exercises. Thank you.
Wonderful talk, Dr. Swarroopa. In interest of time, maybe we'll go ahead with the next talk,
Yes.
but thank you. Wonderful work.